So Dr. Anand, you can switch on your video now. I think Dr. Anand has left again. Okay, we'll start the meeting. So welcome all friends to Saturday Club morning meeting again. And today's topic is very interesting because last month we read about a lot of Guillain-Barré syndrome cases coming up in and around Baroda. And we are all wondering how can this, how this outbreak has happened. So to understand GBS and then to understand the epidemiology of this particular outbreak and how it was investigated, we have two very eminent faculties with us. One is Dr. Vishal Patel, who is a practicing pediatric neurologist in Baroda. He did his MBBS, DCH and DNB, and then he did his fellowship in pediatric neurology at Jaspro Hospital and Wadia Children Hospital at Mumbai for 2 years. And then he worked as ex-clinical associate pediatric neurology at KDA Hospital, Mumbai. And he has some very interesting research publications. And what I just read was about Kleepers, a very rare syndrome related to chronic HLH of CNS, which I think you have published it, right, Dr. Vishal?
Yes, sir. Yes.
It is one of the rarest cause because according to what I read in his CV, this is only second case reported in the world. So we have Dr. Vishal Patel with a lot of knowledge, and he is a very popular neurologist in Baroda, easily approachable. So he will first present the GBS theoretical aspects and his experiences with some of the cases which he handled recently. And then we have Dr. Anand Sontakke. He's a surveillance medical officer of WHO, and he played a very major role in polio eradication. All pediatricians in Baroda would remember him visiting our clinics very frequently, calling up, making presentations regarding making us aware about polio surveillance. And that's why probably people like him who helped us in almost eradicating polio from at least India, because our surveillance, Indian surveillance of polio has been one of the best. The very fact that we have not had any cases for last 9 years now, I think the credit goes to people like Dr. Sontakke, who are very, very vigilant, very persuasive, and always calling all the pediatricians about reporting of cases, which was a backbone of this eradication. And he is also playing a great role in strengthening of routine immunizations and VPD surveillance. Still, we get a lot of calls from him regarding measles and other reportable VPDs. So welcome, Dr. Sontakke. So now we start the meeting with Dr. Vishal first presenting his presentation on GBS, what GBS is, and his experiences of handling some cases in the recent outbreak. So Dr. Vishal, please.
Yes. First of all, thank you, sir, for inviting me as a guest speaker in the Saturday Club meeting. So, as sir told, first I will give the theoretical aspect of the GBS, what is the GBS, how to manage and how to diagnose. So without wasting time, I start my presentations. As we know, after the polio eradications, so Guillain-Barré syndrome is one of the most common cause of the acute flaccid paralysis in pediatric population. So it is well known to not only for neurologists, every pediatrician, every physician, even the GP level also is a well-known disease. So as we know, Guillain-Barré syndrome is the acute immune-mediated polyneuropathy, which is characterized by acute flaccid paralysis without sensory and autonomic disturbances. It occurs in all age groups from age of 1 to the adult age up to 60, 70 age is there. So it is well known and it is more common in the adult compared to pediatric populations, and also is more common in the male gender compared to female genders. So if we know about the incidence, so average incidence in the India is 1 to 2 cases per lakh populations per years. This is the average the incidence, but these incidence vary according to geographical areas. This vary from the 0.4 to 4 cases per lakh per years. So details about that, Dr. Anand will talk in later on. So pathophysiology of the GBS, as we know, GBS pathophysiology is not actually clear, but most accepted theory is the autoimmune mediated disorders. Means the some previous infection, viral infection occurs that cause the molecular mimicry that generate the autoimmune antibody against the myelin sheath of the nerve. So that is the most accepted theory for the pathogenesis of the GBS. Preceding viral infection, most common is the Campylobacter, jejuni, influenza, CMV, EPV, herpes groups, and adenovirus. In these lists, one more added after the COVID pandemic, COVID-19. That is one of the main reason nowadays, last 2 years, the GBS. But how to correlate that, Dr. Anand will tell you later on. But we see the whatever the cases in the last 2 years, that's all the patients. I did the all patients with the COVID antibodies that's strongly positive in majority of the cases. So that suggests that is one of the etiology immune reactions that cause the GBS. And also known the second etiology is the previous vaccinations. Most common is the influenza and the rabies. That is very known that after these vaccinations, GBS can occurs. These two is a well-known etiology. Other the few case report is that the GBS can occur after the head trauma, surgery, and bone marrow transplantation. That is a few case report is there, but it's not commonly seen after this etiology. So this is a picture of the pathophysiology of the GBS. If you see, this is left side is the AIDP pathology. This is the AMAN. AIDP means acute inflammatory demyelinating polyneuropathy, and AMAN variety means acute motor axonal neuropathy. So I am not going details, but here you can see this pathophysiology start with the T cell that the converted into TH1, TH2, and TH17. TH1 and TH1 generate the T cell mediated the inflammation reactions, and TH2 is the mature the B cells, and that's converted into plasma cells, and that generate the antibody, and that also one of the cause for the AIDP type of the GBS. So in summary, is the AIDP pathophysiology is both T cell mediated and the B cell mediated. The immunity is major response is there. Compared to AIDP's AMAN variety, so mainly is the B cell mediated immunity is responsible for the AMAN variety of the GBS. So clinical presentation, as we know, the cardinal feature is the ascending, classical ascending type of the illness, means the start with the lower limb weakness and gradually weakness is ascending that involve the upper limbs, then the respiratory muscles and the cranial nerves also. Usually is a symmetrical weakness, but yes, nowadays after this COVID, we see the asymmetrical weakness. Recently, I saw the one patient start with the left lower limb weakness. After few days, start with the right upper limb weakness. But when I examine, is there other limb weakness also is there, but mark asymmetry is there. So these are the heterogeneous presentation is very known after this COVID pandemic. So nowadays is GBS not the classical presentation like the all the ascending paralysis presentation is there. Second symptoms is the pain. In the pediatric populations, most common less than 5 years, most common presentation symptoms is the pain, because of the pain they can't able to walk. So we can't judge that there is weakness or not. So these pain symptoms sometimes mimic like the other DD, like the post-viral myositis. That always confuse this. This is post-viral myositis or GBS. So pain is most common symptoms in less than 5 years compared to adults. Third most common symptoms is the cranial nerve palsy. Most common is the facial nerve. After that, the glossopharyngeal and the vagus nerve, and then the 3, 4th, and 6th nerve. So most common is facial weakness in the cranial nerve. And also, as I think the 30 to 40% patient also has the autonomic disturbance in the form of the tachycardia, bradycardia, hypertension, flushing is there. So this is the classical clinical presentation of the GPS. Some GPS variants also is very known that the electrophysiologically mimic like looks like the GPS only. So these are the most common is the Miller-Fisher syndromes, which is the characterized by ophthalmoplegia, ataxia, areflexia. This is the triad well known for the Miller-Fisher syndromes. And majority of these cases we found the anti-GQ1B antibodies positives. It helps us to confirm the diagnosis also and the further treatment also. Second most common variant is the pharyngocervical brachial syndrome. This is most common in the adult compared to pediatric populations. This is characterized by localized and regional involvement of the motor nerves, like the poor gag reflex presentation is the poor swallowing, the change in the voice, and the upper limb weakness is there. That is not progress to lower limbs. Very rare, the variant is the polyneuritis cranialis, which is presented as acute onset of the multiple cranial nerve palsy, usually is 3, 4, 6, and 7. These sometimes mimic as the post-viral nerve palsy, but in this case, the report many case report is there. If you evaluate this patient also showing the like the GPS changes in the CSF showing the albuminocytological dissociation plus NCB showing the demyelination changes. So this is the very rare variants. On physical examination is the weakness is the predominant features, which is more common in the proximal area than the distal area.
So
And the deep tendon reflexes usually is hyporeflexia or areflexia. But sometimes we can see the hyperreflexia at the start of the disease. But that the DTR hyperreflexia, that's the one of the red flag sign. We have to consider some other etiology also. But yes, it can be seen in the GPS also. Second is I discussed the cranial nerve palsies. That is one of the poor prognostic factor. If the patient has the cranial nerve palsy at the time of the admission, so that suggests a poor prognosis. Then the dysautonomia, most common is the tachycardia and hypertension is more common. The physical examination more the specific test, I can say the SLR test, straight leg rising test. If it is positive, that more specific to GPS rather than the other etiology that usually like the transverse myelitis also sometimes mimic as GPS. But if you find the SLR positive, so you are more sure about the GPS. And in GPS, there is no any sensory level like we see in the transverse myelitis. And the single breath count, it's very important to monitor the patients. As we know, this is the ascending paralysis gradually involve the respiratory muscles. So you can monitor the patients, the respiratory involvement is prone or not. So you monitor the single breath count, usually is 30 to 40 is the normal range. But if you find the less than 50, so you can red flags and might be patient is involved the respiratory muscles. And if the single breath count is less than 7, so definitely patient require the mechanical ventilation. So this is the non-invasive test to help us to monitor the progression of the disease. We not every time pick for the ABG. Sometimes we have to know this is the respiratory acidosis going on or not. But these the non-invasive tests which help us to monitor the respiratory muscle involvements. So what are the red flags that in that cases we have to suspect some another etiology rather than the GPS, like the marked persistent weakness at the onset. If you find the sudden onset of the weakness and that is very severe, so that is one of the red flag signs. Bowel bladder dysfunction at the onset, persistent bowel bladder dysfunctions, In CSF, you find the mononuclear leukocytosis more than 50, and the sharp sensory level means you can match the proper sensory level T10 or T12, whatever. So these are the red flags you have to suspect the other etiology rather than the GBS. Most common, these are the symptoms, sign of the transverse myelitis. That is usually is mimic the like the GBS. Because why important? Because sometimes the wasting money for the costly therapy IVI, we just because methylprednisolone treat this transverse myelitis. Yeah, we know the transverse myelitis in the IVIG also is helpful in the transverse myelitis. But first drug of choice is the methylprednisolone. That is the very cost effective. So that's why we have to know about this red flag sign. So what is the poor prognostic factor we can predict at the time of the admissions if adult has a severe deficit at the admission point of if patient require the mechanical ventilations cranial nerve involvement and autonomic disturbance at the time of the admission, this suggests a poor prognosis of the GBS. So diagnosis, as we know, this is the clinical diagnosis because initial the phase we this is classical. We see the ascending fallacy, we diagnose clinically. But nowadays, so many of the variant I discussed different type of the weakness, not the always follow the ascending weakness. So sometimes we require the objective evidence to confirm the diagnosis. Most common is the NCS study, now conduction study, and MRI spine with contrast. So MRI spine with contrast, we usually see the nerve tenant spine. That is the more sensitive test, early sensitive test for the diagnosed GBS rather than the NCS. But that we require the proper the radiologists for that interpret the reports because sometimes the minor nerve tenant spine can be missed. So, but its MRI is the most sensitive test for diagnose the GBS. Regarding the NCS, I will discuss in the next slides. CSF, as we know, is showing the classical albuminocytological dissociation means the cell count is less than 10 and but protein is more than 55. So this is one of the classical picture of the GBS in CSF. But nowadays we diagnose the GBS by NCS and MRA. So nowadays we not do the routinely CSF because the CSF is finding we see after the 1 week or 2 weeks. Initial stage can be the this CSF picture is normal, but we have to start the early treatment. That's why the test is not much help the early starting treatment. So now conduction study is the most earliest and the sensitive finding is the prolonged, inconsistent or absent F-ray. This is the earliest finding by which pick up the this is GBS or not. I can say within the 48 hours of the onset of the symptoms we can find. Later on the depending on the which type of the GBS we find the now conduction finding. According that we divided AIDP or among variety. In demyelination we usually find the prolonged latency and the decreased conduction velocity. And the among variety we found the decreased amplitudes. So this is the table showing the how to differentiate the AIDP, Amman and the Amson variety. Amson means like the acute motor plus sensory axonal neuropathy. In AIDP types, clinically, how do we suspect is the gradually progressive weakness rather than the sudden onset of the weakness. So that is a characteristic finding of the AIDP. Plus in AIDP also you find the sensory and the autonomic disturbance also, and also is some cranial nerve involvement. In the NCS wise, the classical finding is the decreased conduction velocity and the prolonged the latency. This is the classical finding for the AIDP. And involve there is no any routinely be detectable any antibody in these types. In Aman variety, we usually find the sudden onset of the weakness and that only involve the motor nerve and not involve the sensory and the autonomic nerves. And also is very less common the cranial nerve palsy in the Aman variety. And as we discussed the NCS, we found in the Aman varieties decrease the amplitudes rather than the prolonged latency and the decrease the conduction velocity. But many of times we see the mixed pictures. We can't differentiate this is AIDP or Aman. So mixed picture, but sometimes we can comment this is the demyelination is predominant or axonal is predominant. And the Amson variety, as I discussed, the Aman variety plus sensory symptoms is there. So management wise, as we know, the IVIG is the drug of choice, IVIG in the plasmapheresis. IVIG, we have to give the 2 gram per kg over 2 to 5 days, depending on the every individual's preference. But if the child or adult has the autonomic disturbance, then we have to give the gradually over 5 days rather than the 2 days, because IVIG also causes the autonomic disturbance, and that's deteriorate the patients. And second option is the plasmapheresis, which is also is the same efficacy like the IVIG, but depending on the technical difficulty, we usually is not prefer in the pediatric patient as the first lines. But both has the same efficacy in the adult. Many of the centers, the plasmapheresis, they use the first line because the in adult is weight is more than 50, 60. So in that case, it's more the cost effective rather than the IVIG is there. And third is more important point is there is no role of the steroid in GBS, because many of times I see the patient is not affordable for IVIG. So some physician can we try the as a methylprednisolone? Why we give something, but is the steroid is not help, even deteriorate the disease and decrease the recovery of the disease, because steroid is the prevent the recruitment of the macrophage and the scavenger, so that's delay the recovery. So there is no role of the steroids in the GPS in like AIDP types, and the supportive treatment like the mechanical ventilations, neuralgic pain for we have to give the GABA pain, everything, and normal physiotherapy, everything. What the further treatments if we give the IVIG and plasmapheresis, if still the patient is deteriorate, so what is the next steps? So there is no any particular guideline for this after IVIG, what we prefers, second dose IVIG or plasmapheresis. So I will discuss the role of second dose IVIG. Many of the few case report is their second dose of the IVIG is help to fasten the recovery. I also see I tried in the one patient also after 3 weeks of the first dose of the IVIG, child also is the improvement trend is suddenly improve. Rate of the improvement suddenly increase. But now recently is the one the case series double blinded placebo controls case series published in the Lancet. So that suggests the not no role of the second dose of the IVIG. And that case it is mainly patient is the adults. So they mentions it's not help plus also is cause the side effect like embolia, DVT, everything. But usually in pediatric we not usually see the this side effect IVIG cause the DVT, everything very rare in pediatrics. So this is a debatable topic. There is no any particular guidelines we have to give or not. But I personally feel that if we give, so try after 2 or 3 weeks of the last dose of the IVIG. Second is that if we give the plasmapheresis followed by IVIG, this is the well accepted theory in the adults because the plasmapheresis most cost effective. So they try first plasmapheresis followed by the IVIG. If the child patient is still deteriorate, if the deterioration is stopped, so there is no role of the any further immunotherapy. Just then we have to wait. And third is the IVIG followed by the plasmapheresis. There is always the old concept is that if we give the IVIG, then we do the plasmapheresis. So then there is the washout of the IVIG. But nowadays this is not acceptable. Exact reason is I don't know. But yes, after IVIG, we can try the plasmapheresis after 7 to 10 days. That help the further improvements. Not always we have to wait for the 3 weeks. Recently, I tried in one patient, the adult patient is around 17, 18 years. So already IVIG is given, weight is I think 60 plus. IVIG still the no any improvement, still further deterioration. We try the plasmapheresis. After that is recovery slightly improved, but as we say, we can't comment this is a natural recovery here because of the plasmapheresis. So these three treatment is the debatable. There is no any particular guideline for that, but that everyone has the individual opinions for that. So outcome, as we know that this is a very good outcome in the GBS, particularly in the pediatric population. Adult population is poor compared to pediatric populations. When I was in the doing my DNB residency, so my intensivist told me if anyone refer the GBS patient, never say the no. Whatever the severity is there, just accept. You have to just manage the supportive treatments in that case. So mortality usually we see in the less than 5% cases. Initial years, the most common cause of the mortality is the respiratory failures. But nowadays, because of the increased ICU facility, increased ventilations, increased expertise, so nowadays respiratory failure is very less common cause of the outcome. Nowadays, most common is the cardiac arrhythmia. This because of the autonomic disturbance. I saw the one patient, the sudden started of the weakness within 20, I think 12 hours involve the respiratory muscles with the autonomic disturbance. And in that case, we give the IVIG very slowly also. IVIG also cause a further autonomic disturbance, and because of that, his child suddenly demise. Fully recovery occurs in 90 to 95 patients, and residual disability occurs in the 5 to 10% of the patients. Thank you.
Thank you, Dr. Vishal. That was a very brief and comprehensive description of what GBS is and how it is managed. So later on, I think we'll take up some questions about how you manage all these cases. Was there any difference from what you have seen earlier than this COVID-related GBS? So now we invite Dr. Anand Sentuke for his presentation on how this outbreak was investigated.
Hello.
Dr. Anand, we are not able to see.
You're not able to see the presentation, sir?
No, presentation we are able to see. Your video is not seen. That's okay.
Mine, because, sir, there is a problem with the network over here. Okay. So if I keep my video on, then it will be some problem, with the presentation.
Okay. It's okay. Yeah? You can start your presentation.
Yes, yes. Thank you, sir. Thank you so much. Thank you, Dr. Vishal, for giving this wonderful presentation and a brief about GB syndrome. So, as sir earlier said, there are only 1 to 2 cases per lakh population. So, what was new in this outbreak? Like, what was new? What is different? Like, GBS cases are occurring in the community, but what was new? Why we investigated this outbreak? If you see in past that there was a clustering of cases, like in 2011 we found 4 cases in Anand in just 1 week, 5 cases in Arauli in 2015, and even in Anand we found 3 cases in 2018 in a week. But this time it was huge. Like we had a cluster of 20 cases in Panchamal district, 7 cases in Anand district, and 2 cases each in Kheda and Mahisagar district. So if we see geographical clustering, there were 17 cases in Khadifalia Urban Health Center. So Urban Health Center is around 50 to 60,000 of population. So there were 17 cases in 50,000 population, and it was in a very short time. That was like, it was in 15 to 20 days, we could found so many cases of GBS. So when we investigated those cases, when we found personal distribution, so from where the cases came, like 59% of these cases were having a median age of 11 years and mean of 17 years. They were all residents of the same area and having no travel history in preceding 6 weeks. Again, if you see out of 29 cases, 21, so 72% were again from Godhra urban. So from one USC, we had around 17 to 18 cases. So most of them were from urban areas. As Sir rightly said, most were males. So we had 66% of cases which were males, 97% among Hindu community. So if we distribute, 31% were from OBC, 21 from general community, and 21 each from SC and ST community. So the average family size in 72% cases was equal to or more than 5 members. And then again, when we see 94% of cases had no other family affected. So it was an individual case. Only one, we had 2 children affected in same house. 69% cases had pakka houses, then 69% cases were students, and 10% were working in some or other shops, or they were workers. 69% cases, the source of drinking water was tap water, and 14% were using RO water. So most of them were using tap water. Monthly income, if you see 50% of the cases, it ranged between 5 to 15,000. But then again, in 50% of cases, they were middle income community people, and only one case was illiterate. So if you see the map, so geographical distribution you can see. So we had like 31 cases in which 29 responded to us, 2 refused to respond to us. Therefore, the data is for 29 cases, but 20 were from Panchamal, 7 from Anand, 2 from Kheda, and 2 from Mehsagar. So this was the actual geographical distribution of these cases. So clinical distribution, if you see, 62% of these cases were ascending paralysis. But yes, we had around 30 to 35% of cases which had a typical presentation, that mostly the cases had, descending type of paralysis. 86% had symmetrical paralysis. 10% had sensation loss. And we had experienced various degree of dyspnea in 28% of cases. So 8 out of 29 cases. 2% cases had fever during the illness. And in 83% of cases, it took 3 days from paralysis to become maximum to onset. And the longest duration of the onset to maximum paralysis was 5 days in 10% of the cases. So when we saw the severity, so 62% of the cases had severe weakness, like all 4 limb weakness with they were not able to move their hands and feet. 7 were of mild variety, and 31 patient had a moderate severity of symptoms. All received treatment were hospitalized, and 52% were in medical college, and 48% they were treated in private. 86% of them undergone NCV, nerve condition study, and in which 84% were suggestive of GBS syndrome. So all the cases, in all the cases, like 25 cases, NCV was done, and we could found NCV suggestive of GBS syndrome. 3, it was not suggestive of GBS syndrome. We did in 9 cases, we had done CSF examination, and in which 7 of them had changes of GBS syndrome. Out of 29 cases, 22 cases received IVIG treatment, and 5 cases required ventilator support and were put on the ventilator. Out of 29 cases, 8 have been recovered when this data was collected, like 10 days back. They had residual weakness, recovered with residual weakness and without residual weakness. 3 were deaths, and 10% are still, 10 cases were still under treatment at the time of the interview. So we also did a COVID antibody test, uh, and the COVID antibody test result in 5 cases were strongly positive. We had sent this laboratory like test for Zika, dengue, and chikungunya virus, and all. So we tested out of 11 samples. So the first 11 cases we tested nasopharyngeal swab, throat swab, and serum sample, and then we send these samples to NIV Pune, and they tested first for Zika, dengue, and chikungunya, and all samples were negative. All 11 samples were negative. Then they tested it with Neuro 9 RT-PCR kit for 9 viruses, in which in nasopharyngeal swab, 11 cases, 7 samples were HHV virus, then 5 had Epstein-Barr virus. In 5 sample, we could isolate adenovirus, and again HHV6 in 3 samples. So this is all 11 cases what we had sent and what test we had performed, like serum, nasopharyngeal, and oropharyngeal swab, and it was with Neuro 9 RT-PCR kit. So if you see exposure history, they had no history of trauma, surgery, or dog bite, or any new medication. But 8 cases had fever preceding 8 weeks before onset of illness. Then there 2 cases had history of sore throat. 2 cases had history of diarrhea in preceding 8 weeks before onset. 17% had abdominal cramps. So 5 cases had abdominal cramps preceding 8 weeks before onset of illness. 1 case had rash, pruritus, and fatigue, and 12 cases had some. So 12 cases had some or other symptoms like fever, sore throat, rash, abdominal cramps in 2 months before onset of illness. 1 case in each. So if we in the known case, it was a known case of hypothyroidism and hypertension, and was on regular medicines. So we also did a RT-PCR test, and we found that all the cases were negative for COVID RT-PCR test. Out of 29, 14 were tested for COVID antibody test, in which 8 had been tested positive for COVID antibody test. Those who were tested for COVID antibody test, for those who were positive, were below the age of 15 years. So we rule out that they were not eligible for COVID vaccination. So now whatever vaccination we are at that period, it was above 15 years of age. So when we look for a travel history, 3 cases had visited Ankalav, but all cases they were at a different dates, and 2 cases had visited Santrampur. 83% had no history of any vaccination in 2 months. So 24 people never received any vaccine since last 2 months. 5 cases had history of vaccination. So 2 had received Covaxin, and 2 each had received Covaxin and Covishield vaccine, and 1 had received DPT vaccine just within 2 months of onset. 59%, like 17, had attended social gathering, and only 3 of them had commonplace. So they had attended marriages, functions, but then the place was different. Only 3 of them had visited Ankalav village, but again on different dates. 52 had travel history outside their block. So they went out of Godhra, and 7 of them had commonplace village of travel. So what were our conclusions? So this is an GBS syndrome, of course, affecting 4 neighboring districts, with Godhra and block being affected, most affected, and showing clustering of cases. Outbreak is predominantly affecting young urban male children from general OBC community belonging to middle class families. There is no history of common exposure like surgery, trauma, vaccine, medicine, dog bite, insect bite, or underlying any diseases. Neither there is any history of visit to common places or attending social event. all the cases were tested negative for COVID RT-PCR test, thus ruling out current COVID infection as a cause of illness or outbreak. Many of the cases had some or other symptoms like fever, diarrhea, some throat infection before 2 months before the onset of paralysis, suggestive of some infection in recent past. Many of these cases have tested positive for COVID-19 antibody test. So all these cases have tested positive are individual below 15 years of age. Thus, they were not eligible for COVID-19 vaccines. So what we wanted to rule out that COVID-19 vaccine is not the reason for positive antibody tests. Now the reason this may be due to subclinical COVID infection in the past. For throat and nasopharyngeal swab collection from cases, 4 most commonly isolated viruses are human herpes virus, HHV7, Epstein-Barr virus, human adenovirus, and human herpes virus. Serum sample were positive for cytomegalovirus, parvovirus, and Epstein-Barr virus. So what we had an overall impression regarding this outbreak was the GBS was triggered by subclinical COVID-19 infection in the past and presence of isolated viruses in accidental finding. Possibility second was the subclinical COVID infection in the past may have led to lowering of immunity that led infection by the isolated virus, which triggered molecular mimicry leading to GBS in these cases. So these were the conclusion. So we actually, how it helped, this was triggered from a private hospital. You must be knowing Lotus Hospital, we had 4 cases. They flagged this outbreak. Then through our AFP network, all cases were reported. Then we could find the more cases like adult cases were being also affected in the same place. So what we did is like even the state acted very swiftly. They sent their medical colleges team, even the RRTs from the state had visited those places. Then we took all the samples. Even now, this outbreak is being investigated. The more there are other cases which are coming up right now, but the flow is now the cases have lowered. Like the curve, epidemic curve has been lowered. So we get cases, but they are not so like frequent right now. But all those cases, all the GBS cases, even from Baroda, which are admitted in SSG hospital, they are thoroughly investigated, and their samples, nasopharyngeal, throat swab, and serum samples are again sent to NIV Pune for further evaluation. So we will be getting more knowledge about this outbreak in near future. Right now, the best thing was when we investigated, even IVIG was supplied to a civil hospital, and all the patients in, though they were in medical colleges or in private, all received IVIG, and some of them were transferred. Those who were not affordable, they were transferred to medical colleges, and they were all given IVIG treatment at the medical college. So these were the few good points. We could act swiftly. There are only 3 deaths which had happened. Others, they recovered 100%. So their recovery is on. And if the other cases which were hospitalized, they are also recovering. So right now the outbreak is under control. Thank you, sir.
Thank you, Dr. Sunteke. That was a very informative presentation with all the figures, and I'm sure a lot of questions will be there. You can stop sharing the screen so that we can see you.
Yeah. Sir.
Then you can probably start your video also.
Okay, sir.
So in this series of cases, I saw that some cases were not, subjected to CSF examination. Any reason?
Basically, sir, CSF examination, they do it after mostly after, I think, 2 weeks to detect this for GBS. So actually we did this survey like in 7 to 8 days. So whatever the cases, they were old cases. They had undergone this CSF examination. But I think the SSGH Medical College is following up with this cases for CSF examination later.
So in Gujarat, we have seen this outbreak. What is the situation across the country? Like
So
some
across the
of the
country,
WhatsApp group, I am reading that there are some clustering of cases in Delhi also. So what is the experience?
yeah, but then this was very huge, like 17 cases in a span of 15 to 20 days in that Khadi Falia. So we tried to investigate. So this was the largest outbreak, I think, of GBS a country had. Like we had this huge outbreak. So we tried to investigate this. So it can be a learning for two other states also. So what was the actual reason? Because some of them, they correlated it with COVID vaccination. So we wanted to rule out that it is not related to COVID vaccination at all. So maybe that was the reason we investigated. But
That Fadia where there was so much clustering, what was the situation during COVID pandemic? Was this Fadia more severely affected or anything? I mean, retrospective history of that particular locality.
So like we only did COVID test for all these cases, but that needs to be investigated, sir. So we will just go back and we'll see, because these all cases, they never had a history of COVID infection. So we thought that most of the cases had subclinical infection in the past, that they were never tested positive for COVID.
And what was the cause for mortality of this? I think 2 or 3 cases.
Three cases. They were like, and that also due to relatives. That one case in SSJ, the relatives were not, they were asking, the patient was on ventilator and they went DAMA. So the one child, before going to hospital, he died. So these are the two or three cases, like just because one couldn't reach to the hospital and other relatives were not, they were very adamant that we will take the patient to home when the person was on ventilator. So two deaths were actually, it was, if relatives had acted earlier, they could have been saved.
Dr. Vishal, your inputs about managing these cases, no? You are involved in management of some of these cases.
Yes, sir. The management wise, I think I'm not saying any refractory, because this time we see the cases, all the usually respond to IVIG, but I think few cases, 2-3 cases might be resistance require the prolonged ventilations and gradually. But yes, in between I say that after second peak also, 1.5 months, 4 to 6 weeks, I also see the multiple cases in 1 month. I can say the 7 to 10 cases. So that is the usually very large compared to normal incidence. But in that case, it's not the like the particular geography, because this time is particular only the Panchmahal cases. So that is, I think, possibility is strong. The COVID immunity is responsible for these cases, and the management wise, I think the same as we doing the earlier in GPS. But this time is not too much refractory. In between, there is one phase. So most of required the ventilations. Also is the ophthalmoplegia is there in all cases. But this time is good management wise.
Right. Any study on world literature about GBS following this pandemic?
Recently, we have the conference AOP, the Association of the Child Neurology in the Ahmedabad. So in that, we discussed this topic also. But in the outside of the India, whatever they follow the incidents last years and after COVID, so they found almost similar. That is very contrast to our countries. So that is also surprising for me, because in India, in the particular Baroda, I see the last 2 years cases is increasing. But I think that point is already discussed. But in the USA, UK is there, they also insert, because sudden clustering is there. But if you see the all over years data, because this is, we have to calculate not the per month everything, per years, per lakh populations. So they studied this also, but they found that not significant the increase the cases, marginally increases cases there. And also it's proven that is not the particular side effect because of the COVID vaccine. That also point is discussed. COVID vaccine can cause. There is few case report is there, but there is no direct association like the flu vaccine. We see the after that GBS, but like COVID vaccine is not associated.
Right. Any other question from any of the participants? It seems there are not many queries. So thank you, Dr. Vishal and Dr. Sontake, for sparing your time, valuable time in the morning, devoting your time to this Saturday club meeting where we always come up with something which is currently happening in the society, and we try to learn more about it. So thank you for sharing your inputs here on GBS.
Thank you, sir.
Thank you, sir.
Thank you for your for giving us time, sir. Thank you.
Welcome. So we meet next Saturday morning. We'll have Dr. Sainaj Kantharia, and she'll be talking about setting up a clinical research center. Something very unique that is happening at Muni Seva Ashram, and something very unique because we don't see this kind of clinical research setups happening in a charitable institute with a large volume of work. And I always believe that with so much volume of work that we have, the research data generated is proportionately not happening well in our country. So this is something very unique which is happening, and I invite all of you to attend next Saturday's meeting, where we'll have something very different than what you have been listening in last couple of years. This is a research area project where she will be describing us as to how it is set up, and they've got approval from FDA also, and we all know that how stringent this FDA and European authorities are regarding approving such clinical research centers. So please do attend next Saturday morning. We have Dr. Sainaj Kanthai. Thank you all. We end the session.